Thank you. So I'm going to go relatively quickly through this, and some of you have heard me talk about this before, so I'm going to try and get to the data in terms of the outcomes, because we do have some of that now, having celebrated our first anniversary since launch. I will say that I started this, as I said earlier, within the context of newborn screening, and that's because in 2016 we did our first New York State newborn screening study of spinal muscular atrophy, and we went start to finish and very intentionally launched that at the time that clinical trials were starting with the first treatment for SMA. And within a remarkable period of time have gone through getting it onto the recommended universal screening panel and now 3 FDA-approved treatments. As we did that, we started taking our participants within that study and asking them questions about what else they would want in newborn screening and learning from them, and it took quite a while. So we did 4 years of preparation and thinking about Guardian with multiple stakeholders before we actually launched the study, and I will say I think we needed that time to think through it critically, because it informed our study design, which is very similar yet different from some of the other studies that you've been hearing about. All of this is what we heard from parents is we want news we can use. We want information that will allow us to be better parents. I'll explain that for different parents that meant slightly different things, but we did want to do this within the context of newborn screening, minimizing the burden, equalizing and making it equitable for diagnosis as well as for treatment. And within this, the fact that we had many rare disease experts certainly helps our process. Overall, in terms of doing this, we realized that this was a little bit more complicated than some of our previous pilots in SMA or Duchenne muscular dystrophy based on the context. That is about 250 different conditions. So we started the process as in Australia, but informing within the 3rd trimester. At the same time, parents are getting other packets. But postnatally, we also go literally bedside to bedside for each and every parent to be able to explain the study, and we give them up to 30 days after birth to make a decision. So they don't have to decide immediately if they choose not to. We did give ourselves at the beginning a little bit more time for turnaround time because we allow the first newborn screening sample to go through regular newborn screening to make sure we have sufficient sample to do that. We take the leftover residual from the dried blood spot that goes to our public health department, and then we start the process for the genomics screening. And we do whole genome sequencing. We only look at the genes that we say we would look at up front in terms of doing that, and all of these are predicated based on early onset conditions, age of symptoms less than 5 years of age, both at the gene and the variant level that we're doing, and again with some sort of treatability or at least actionability, and I'll get to that in a second and what I mean by the difference. In terms of doing this, we checked and did validation studies because we are in New York State, had a very high bar in terms of validation. I do sort of cringe at the idea of the FDA, but we may need to get to that as well. And within this, again, the ability with whole genome sequencing to allow us the flexibility to either take genes on or off that list. And we will have, starting in early 2024, our version 2.0 of that gene list. So we've done version 1.0 with the genes that are on our website currently, but we know that we can do this in terms of the level of analysis, and so we will be expanding that and also taking a couple things off the list as well. Within this, I refer to these as Group 1 and Group 2. Group 1 is what I would say is squarely in the interface in terms of traditional newborn screening. Group 2, though, is based on participant feedback about largely neurogenetic conditions associated with epilepsy, with treatment available for the epilepsy and being able to control that, providing perhaps a better outcome in terms of neurodevelopment, but those are not completely cures. And so within that, we afforded individual participants being able to, if they sign up for Guardian, they do Group 1. Everyone does Group 1 in Guardian, but with the optional module, if you will, of Group 2, and being able to just gather empirical data to understand what people would do with that. As I said, within this, these are highly penetrant alleles. We couldn't guarantee 100% penetrance because I don't think in point of fact, we know the real true penetrance for some of these things, but greater than 90% penetrance was what parents felt was news they could use. And as I said, within this division of those two groups. Within this, as we're going through this, I did put in one specific example. I will say they're problematic genes, and for anyone who's really interested, I'm glad to sort of have an offline discussion with problematic genes and variants, but I think we as a community have some cleaning up to do of our house as we go forward, and I think we'll realize that as we're doing population-based screen as opposed to diagnostic testing with people who are symptomatic. Within this, we do have a very diverse community in New York City. I did that quite intentionally when I was at Columbia because it allows us us to be able to look at the world, literally in our backyard in New York. As we did this, we did have to decide this threshold of sensitivity and specificity, and we don't think we're perfect in either dimension. We're compromising within this. But for dominant and X-linked conditions, we set a very high bar, whereas for recessive conditions where we can have an orthogonal means of confirmation, we bring that bar down just a little bit lower in terms of one path or likely path variant, and the second being potentially a variant of uncertain significance, leaning towards likely pathogenic. If and when there are new ACMG guidelines, which I believe there will be soon, we will, of course, adhere to those and be able to set that threshold, but that's been very helpful from an equity point of view. Within this, I won't go into details, but we can do all of this technically. There are some genes that we are continuing to work on from technical aspects. And now getting to the data, as we've done this, we only operate right now 5 days a week. We don't do 7 days a week going around to consenting, so that's the reason why we don't get every single eligible baby. But of those, we approach 73% of parents are agreeing to do Guardian, and of those, this is 83% results, is because not everyone have I resulted today. Everyone will get over that finish line. And as we're doing this, almost everyone is consenting while they're still in the hospital. Some people take 2 or 3 visits with us before they go home, but it's only about 4% that'll do this after discharge. You can see on the right that we have a very diverse community. That's great. It pushes us. It's hard, I will say, but it's good that it pushes us. In doing this, this is looking at turnaround time, going from the time of launch to the current time, and in a good way, you can see that it's come down significantly. We're now less than about 21 days. Again, we have to do regular newborn screening first as we go through, and we're improving the turnaround time because as we're getting up to scale and volume, we just are doing things in an automated way every single day rather than batching them, which is what we were doing at the beginning. Within this, our screen positive rate is running about 3.5%. We didn't know what it was going to be at the beginning, but it is now running about 3.5%, and the positive predictive value overall for all of those 3.5% is 87%. So when we go through and do orthogonal confirmatory testing, for the most part, we are returning true positives. We are not surprised that we have some false positives. So we did that very intentionally. And within this, we're getting to know better particular genes and variants, and I won't go through it in detail, but we now know based on our own little community within New York City, some alleles that have previously been ascribed in the literature as being pathogenic or likely pathogenic that really are not. We have more information about phasing, and again, this is proband only, baby only, so we don't have parents at the time we do this, but we now have much greater specificity and detail, and I can go through in detail for anyone who's interested offline. I do want to quickly go through some key results just so that you understand the types of things that we're seeing. Within this is just one example, but of many of the positives. This is a baby who had long QT syndrome. Just to explain the whole process, that baby I called in terms of that result for long QT1. We brought the baby in to do an EKG. In fact, the baby does have a prolonged QT interval. We did the parental testing. We identified that this was a de novo mutation, made sense within the context of no family history. De novo mutations for these conditions can be associated, especially I should say de novo conditions, but any variants can be associated with sudden infant death syndrome, but the de novo variants are especially lethal. The penetrance in terms of them much higher than it is for simply inherited variants, and one can understand that from a population selection point of view. This baby now on a beta blocker is being seen by a pediatric cardiologist, tolerating everything very, very well. Inexpensive medication, beta blockers, long experience with this, and the family's doing well with this information. I should say this is a family that just based on their social circumstance, I'm quite confident would not have been diagnosed otherwise. This is one of the biggest, in some ways, impacts. This was a child who has a severe combined immunodeficiency that was missed on traditional newborn screening, even though we do a TREC assay in New York. This is because this is what some call leaky skid in terms of this. We went to, and again, it takes a team approach in terms of this. I can tell you when I called the parents within this, having prepared my team in immunodeficiencies ahead of time to be prepared for the baby as soon as I called them, I I called the baby that morning. Within 2 hours, we had them in clinic, being able to be literally sort of shepherded in to avoid any infectious contacts as we did that. We did the immunological workup to be able to show that functionally we actually had evidence of an immunodeficiency, which we did. We had case precedent based on the literature that this particular version of the SCID was previously associated as being lethal or requiring a bone marrow transplant, convened a national group of experts in severe combined immunodeficiency to review the data, review the case, and to be able to give us input on this. And the recommendation was to do a bone marrow transplant, and that baby now has been transplanted and is stable post-transplant. But that's what I mean when I say we have to be committed to going the whole way as we're doing this. We do have ability to bring experts around the world to do this. And with this, again, this particular social circumstance, I can tell you that this baby would not have been diagnosed, I'm convinced, without this. Just finally to say a group 2 condition. This was a child who was diagnosed, and I think we'll get better at this over time, with Rett-like syndrome with a mutation in CDKL5, a de novo variant. Exactly simultaneously with this, she actually presented and was admitted with epilepsy. The advantage of this is that we knew this information basically as she was starting her seizures, this information for her neurologist to be able to use in combination with her treatment, and a de novo mutation, again, being helpful to those parents for thinking about reproductive planning, as well as our early intervention strategy and knowing what we need to do and what we don't have to worry about. So within this, I'm afraid I'm out of time, so I won't go into detail, but to say that the participant feedback from this has been overwhelmingly positive, both for those that screen positive and negative. We take the details in terms of doing this, and to say that I do think it's possible, but we started slowly, so I'm saying this for those of you who are launching, we have a way to throttle this so we can increase or decrease volume as we see issues, and I do think that's important to be able to do. And we're still taking nominations for anyone here or listening. The email address is here, and we've had great community engagement in terms of taking nominations. So with that, thank you.